Good morning, everyone. So we will be discussing unknown substance overdose. Many times, patient of unknown poisoning comes to the ER, and then you are asked. You get an unreliable history, and then you are designated to understand which poison it is. So basically, as a critical care physician, you should be able to have some differentials in your mind. What you are thinking, which poison could it possibly be, so that you can plan your treatment accordingly. So this is the data of commonly encountered poisons, and you can see snake bite, pesticides, medicine overdose. These are the common poisons that we encounter in our routine setup. So now let's come to the case which we encounter very commonly. So patient is dropped off at the ED door. He is minimally responsive. His friends say they think he took something and drive off. Now, where do we start? Okay, now how do we start in this patient? What will you do first? Okay, airway, breathing, circulation, ABC. Okay, we have done that. After that, okay, which syndrome you want to look at? Okay, very good. Pupils dilated or constricted. Okay, what? Very good, very good. Tachycardia versus bradycardia. And third, anything else you want to look at? Temperature. So you want to see hypothermia versus hyperthermia. So let's see what are the differentials in each of these three common headings which we want to look at. So any patient who is an undifferentiated poison, you want to look at these things: tachycardia versus bradycardia, hypothermia versus hyperthermia, and pupil dilated versus constricted. It will give you some idea where we actually are heading in terms of which poison. So how many of you do urine toxicology as a screening marker? And how many times is it helpful? Never. So we do this test, I think mainly for medico-legal purposes, but as a test, whether it really is helpful or not, we are not sure. Moreover, if you give midazolam during sedation for any imaging and all, you will invariably see benzodiazepines positive. Well, when actually it might not be a benzodiazepine. Okay, so collection of symptoms associated with certain classes of poisons is known as a toxic syndrome or a toxidrome. It may be the only clues to the diagnosis. And diagnosis is complicated by the possibility of multiple drug ingestion. And we should always rule out other primary clinical causes because mainly it's a diagnosis of exclusion. So you have told me rightly A, B, C, D, E, F, G. Okay, this is what we say for a poison. So E is enhanced elimination, F is focused therapy, and G is get toxicology help. And obviously the history, physical examination, toxidrome recognition and diagnostic test. They are important part of the overall workup. So this is a don't mnemonic which we remember: dextrose, oxygen, naloxone, thiamine. When you don't know anything, always think of these things. And then accordingly, if you want, you can, if you think it's a opioid, pupils are constricted, you're thinking on those lines, then obviously you can give antidotes accordingly. Okay, you always have a two-pronged approach. So whenever you are encountering a poison patient, you always have this two-pronged approach to deal with it. So history you will often find unreliable, especially if family member has not come. And they will say there may be an empty container nearby. The patient may be taking certain previous medications. He may be a diabetic, hypertensive, liver, renal disease. So those medications may be found, and then there may be a history of substance abuse in the patient. Obviously, medico-legal reporting is one of the important things, and next we obviously come to the recognition of toxidrome. So we look for pupils, dilated versus constricted. We look for skin temperature, hypothermia versus hyperthermia, and we look for odors if there are any. So I think let's identify one by one. So first, bradycardia versus tachycardia. So which drugs or poisons you know can cause bradycardia? Okay, name a few poisons which you know can cause bradycardia. Opium, okay, opioids, okay. Anything else? Beta blockers, okay, beta blocker overdose, yes. Anything else? Yes? Yellow? Okay. Okay, anything else? Any commonly used drugs or commonly used poisons which you know can cause bradycardia? Yes. Dioxin, very good. Dioxin toxicity you all know. Anything else? So beta blocker, dioxin, any poison? Okay. OP, anything else? Sulfos. Sulfos is basically a cardiotoxic poison. Not necessarily you will always find a bradycardia, but it is a cardiotoxic poison. Okay, it definitely impacts the heart functions. Okay, anything else? Okay, so this is the list. Mnemonic is paste. Propanolol, anticholinesterase drugs, clonidine or calcium channel blockers, ethanol or alcohols, and digoxin or digitalis. Okay, tachycardia. Which poisons cause tachycardia? Yes. Okay, which drugs cause tachycardia? Okay, anything else? Theophylline. Okay. Which group of medicines cause tachycardia? Sympathomimetics. Okay. Anything else? Cocaine. Okay. Anything else? Cocaine is a sympathomimetic. Okay. Alcohol will come in both the categories. Okay, I agree. Okay. Anything else? Amphetamines. Okay. Again, a sympathomimetic. Any other category of drug or a poison which can cause tachycardia? Okay. So this is the list. Mnemonic is fast. So cocaine, anticholinergics, sympathomimetics, theophylline, TCAs and thyroid hormones. Okay, now I come to hypothermia. Okay, which poisons cause hypothermia? Or which drugs cause hypothermia? Okay, opioids. Any other drug which you know or a poison which you know will cause that will cause hypothermia? Alcohol obviously I can understand it will come in all the categories always. So very difficult to identify. Okay, anything else? Anything else? Okay, which conditions do you encounter hypothermia? Think it like that. You will get your answer. Thyroid. Okay, so medications related to thyroid obviously can cause it. Anything else? Okay, so this is the mnemonic for hypothermia. It is cools, carbon monoxide, opioids, OHAs, liquor or alcohols, and sedative hypnotics. Okay, which poisons cause hyperthermia? Increased temperature. This is easier. Okay, one. Anything else? Thyroxine. Okay, anything else? Anticholinergics. Atropine is known to cause fever. Okay, anything else? Antipsychotics. Okay, anything else? Okay, so this is the mnemonic. NASA, neuroleptic malignant syndrome or nicotine, antihistaminics, alcohol withdrawal, salicylates or sympathomimetics, anticholinergics, antidepressants. Uh, Now we come to meiosis. Okay, which poisons cause meiosis? Opioids. Okay, anything else? Okay, anything else? Four. We need to remember four. Obviously, constricted pupil. We first think of these two. Yes. Anything else which you can think of? Anticholinergics will cause pupillary dilatation. Sympathomimetics. Sympathomimetics. Okay. So pontine hemorrhage, a medical condition which will cause constriction of pupils. Then opiates, organophosphates, cholinergics, carbamates, clonidine, and sedative hypnotics. These will cause. Okay. Which drugs or poisons cause mydriasis? Atropine. You all know. Anything else besides atropine? Sympathomimetics will cause pupillary dilatation. Yes, it was not cause meiosis. It will cause mydriasis. Okay. Anything else? Okay, okay. Anything else? Any other poison for mydriasis? Sympathomimetics, amphetamines will all cause mydriasis. Okay. Sympathomimetics, anticholinergics, alcohol withdrawal. This is the three commonly implicated for. So now you understand the toxidrome. Three things to identify, differentials to be lined out, and then you try to identify which poison it is. Okay, so this is the routine test which you do in most of the poisoning. Electrolytes, renal function, sugars, Anion gap. Okay, which poisons cause high anion gap or drugs? Okay, methanol. Okay, anything more? Okay, where do you see high anion gap? High anion gap metabolic acidosis. Where do you encounter? Which conditions? Yes. Okay, yes. More. List is long. There is a good mnemonic to remember it. Yes, always ask in exam. Mud piles. Okay, now elaborate mud piles. Yes. 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 Okay. Now, which drugs cause low anion gap? ये मुश्किल है. नहीं नहीं, ये भी आसान है. ये रोज यूज करते हैं हम ड्रग. हमारे ऐसे में रोज लिखते हैं हम. ओके चलो ठीक है, वो दैट आई मतलब डायरिया इज वन ऑफ दोज, बट नाउ वी आर डिस्कसिंग ड्रग्स एंड पॉइजंस. ओके, विच ड्रग और पॉइजन कॉज लो anion gap? लिथियम. वेरी गुड. ओके, वन मोर. रोज यूज करते हैं बट हम देखते नहीं है एबीसी में कभी. Polymyxin B. Polymyxin B is known to cause low anion gap. Okay. Okay, so serum osmolality plus osmolar gap. Which drugs cause high osmolar gap or poisons? Methanol. Okay. This is what you remember always, because this is always a common exam question. Okay, so this is the list of raised anion gap. I think you have discussed most of it. Methanol, ethylene glycol, toluene, alcoholic ketoacidosis, lactic acidosis, acetaminophen, cyanide, isoniazid, DKA, generalized seizure, salicylates and paraldehydes. Okay, and low anion gap, hypercalcemia, hypermagnesemia. Two common electrolyte imbalances where you will encounter low anion gap. Then lithium, and then after that hypoalbuminemia and polymyxin B. Okay, so how to calculate osmolar gap? You know the normal serum osmolarity 285 to 295, and this is the formula to calculate the osmolar gap, measured minus calculated. And increase in osmolar gap indicates the presence of low molecular weight osmotically active substance in the serum. So agents which increase osmolar gap, it is methanol, ethylene glycol, diuretics, isopropyl alcohol. So any more or less all related to alcohol. Okay, low osmolar oxygen saturation gap. Now this is a term where there is a more than 5% difference between saturation calculated from ABG and what you get from the pulse oximeter. Normally it is due to abnormal hemoglobins. So you will encounter it in methemoglobinemia, carboxyhemoglobinemia, cyanides and sulfhemoglobinemia. Now during investigations, when you do abdominal x-rays, sometimes you may find radio-opaque pills or a drug-filled packet, and on an x-ray you may find findings of aspiration pneumonia or a non-cardiogenic pulmonary edema, acute lung injury. So which poison is known to impact the lungs? Okay, which poison causes lung fibrosis? Which one? Paraquat. Okay, how do you treat paraquat poisoning? Hemoperfusion. Okay, yes. Okay, it has been written in textbooks. Okay, anything else? What else do you do when when a patient of paraquat poisoning comes? Hemoperfusion, I agree. Avoid oxygenation. Okay. Anything else? Okay. So see, the literature says ECMO, even a lung transplant, even if you do a lung transplant in a paraquat, it will come back. So it is one of those poisons which is very difficult to treat. People have tried pulse doses of steroids also in paraquat poisoning, but still, as of now, it is one of those poisons which will always remain very difficult to treat. Okay, which poison affects the heart? Yes. Which poison directly affects the heart? Decrease the ejection fraction. Sulfos. Okay, how do you treat sulfos? क्या करते हैं sulfos में? V-ECMO. Okay, V-ECMO is one. I agree. Anything else which has been written in textbooks which you can try if you don't have ECMO, minus ECMO. Is there any role of balloon pump in triotic? Not much literature. Okay. People have tried coconut oil to delay the absorption. That is okay. So this is something which is available on a abdominal radiographs. So cocaine packets, opium packets, iron, neuroleptic agents, sustained released enteric coated agents. Now toxicology screen we all know rarely needed and not very helpful. You get high rate of false positives and negatives and it rarely changes the management. Okay, so I'm not going into details of it. I think most of you know what are the symptoms of anticholinergics. So you have dilated pupils, you have dry skin, you have retention urine, uh, tachycardia, hypertension. So you remember this by this mnemonic: hot as a hair, dry as a bone, red as a beet, blind as a bat, and mad as a hatter. So cholinergic, I think you know most of it: urination, meiosis, bradycardia. These are the common signs, and treatment is with atropine or PAM. Sympathomimetics, again you know: mydriasis, tachycardia, hypertension, and hyperthermia. Okay, beta adrenergics: tremor, tachycardia, hypotension. Okay, so common categories of drugs which we see: serotonergics, flushing, diarrhea, fever, trismus, tremors. Okay, opioids you know: meiosis, bradycardia, hypotension. And then hallucinogenics, where there is amphetamines, cocaine, so they will cause mydriasis. They are actually sympathomimetics. And then there is another category of sedative hypnotics like anticonvulsants. Okay, now let's try to solve this. So the patient comes to your emergency and you have a pinpoint pupil and vowel sounds are hyperactive. Now what is your differential? Pinpoint pupil with a hyperactive vowel sounds. What is your answer? ओपियॉइड में हाइपर होंगे, हाइपो होंगे? हाइपर किस में होंगे? Okay, so cholinergic, hyperactive, hypoactive it is opioids. Okay, now normal or dilated pupils and hyperthermia or hypothermia, and now answer. What is your answer? Normal or dilated pupil, hyperthermia with a hyperactive vowel sound. Okay, and what about hypoactive? Yes, sympathomimetics. Okay, sympathomimetics and anticholinergics. Okay, if it's a hypoactive vowel sounds, it's an anticholinergic. Okay, now what about this? Normal or dilated pupil, hypothermia and hyperactive vowel sound. What is your differential? मुश्किल है? चलो, okay. So hyperactive is hallucinogenic, hypoactive is sedative hypnotic. Okay, so this is how you identify a toxidrome and you try to identify a poison. Okay, so you know the treatments. I am not discussing into detail. Coma cocktail, dextrose, naloxone, thiamine, most commonly used. If there is a seizure, you will use a benzodiazepine or a barbiturate. ECG monitoring to identify if it's a bradycardia or the type of poison. And then you have methods to decrease absorption, to increase elimination, and antidotal therapy where you have multidose activated charcoal. Okay, where do you use urinary alkalinization? Which poisons? Okay, TCAs. Anywhere else? Okay, where do you use activated charcoal? OP में हम activated charcoal. Okay, and yes. Antipsychotics. चलो OP I will say ठीक है. चलो let's see. So skin and eye decontamination commonly practiced in OP poisoning. GI decontamination, and then I am not discussing how to do a GI decontamination with active charcoal. Now let's identify the conditions where we come across. Okay. So now substances absorbable by activated charcoal: anti-malarial, barbiturate, carbamazepine, and dapsone. And substances not absorbable by activated charcoal: pesticides, hydrocarbons, acid alkalis, iron insecticides, lithium, and solvents. Okay, so now enhanced elimination. So urinary alkalization and extracorporeal elimination. So where do you use extracorporeal elimination? Okay. So urinary alkalization is you want to make urine pH more than 7, you use it in salicylate poisoning and you use it in phenobarbital uh, poisonings. Extracorporeal, which means hemodialysis. Okay, which poisons are removed by hemodialysis? Which poison you want to do a hemodialysis? Methanol. Alcohol सबसे confusing poison है. Always. Hmm. Okay, salicylates. Anything else? Lithium. Okay. So this is the list. Salicylates, theophylline, alcohols, lithium, ethylene glycol, which are accessible to hemodialysis. Okay. Then charcoal hemoperfusion you will do in carbamazepine, paraquat, barbiturates, theophylline. These four category of poisons we would like to do a charcoal hemoperfusion. Okay, antidotes, you know. Chalo, let's end this by MCQ. Let's see whether you can identify this poison. So, 53-year-old woman with a history of diabetes, hypertension, CAD post PTCA, and personality disorder and suicide attempts was found unconscious at home. She was lethargic, heart rate, she had a bradycardia, BP of 57 by 24, lactate of 7.2, tropoid 2 sets negative. And this is the ABG, 7.26, PO2 112, 19.3 BICA minus 5.6. Okay, what is your answer? Yes? Beta blocker poisoning. Okay. Now, does your opinion change or you are still convinced it is only a beta blocker poisoning? Okay. Why are you thinking in terms of opioid bradycardia? Because you are thinking it because in bradycardia. Okay, so we have two differentials right now. One is beta blocker, one is opioid. Anybody has got any other differential in his mind? CCBs. Okay, very good, very good. Any other differential you are looking at? Aspirin. Insulin overdose. Okay, okay. Anything else? Digoxin. Okay. Now, how do you try to rule out? Now, let's try to rule out one by one. Which poison it is? Okay. So, okay, we have now identified it. We have got five differentials in our mind. Now, how do you treat? So, you may have five differentials, but the predominant issue is now we have to treat this bradycardia and hypertension first. And then we'll try and identify which poison we are dealing with. Okay, now what do you do to treat the bradycardia and the hypertension? First thing, which will you do? Atropine. Yes. What do you want to give? Sugars. Okay, you want to check sugars. Okay, sugar is normal. Now what do you want to do? Atropine. एट्रोपिन देना है, एड्रिनल इन्फ्यूजन देना है, डोपामिन इन्फ्यूजन देना है, कॉमनली कर रहे होते हैं हम, या कुछ और करना है? Okay, so you want to build up the blood pressures, you give crystalloids, you give atropine, you try and treat the bradycardia with the conventional bradycardia algorithm, so which may include a dopamine infusion also. What is the next thing which you want to do after this? Sugar is normal. Okay. So you want to give calcium, you want to give glucagon. Okay, why do you want to give glucagon? What is the treatment of beta blocker poisoning? Glucagon or insulin? Okay, so heart rate improved to 62, BP is still low, patient is still drowsy. His lactate have just marginally improved to 6.5. Now what do you want to do next? Next क्या करें? ब्लड प्रेशर अभी भी इंप्रूव नहीं हुए हैं. Okay, NORAD, vasopressors देने हैं, ठीक है. Anything else which you are thinking? Now we want to treat the poison and we want to give an antidote, and we are looking to give an antidote because you should have a strong index of suspicion when you are dealing with this kind of poison. Because symptomatic therapy will work only to a certain extent. It will return. The rhythm will return. Okay, you have tried symptomatic. Now after this what? You have intubated because patient was drowsy. You have given epinephrine dopamine infusion. You have given a glucagon infusion. Now what next? Okay. ABG, I have given you lactate is 6.5, only minimal improvement. Patient is passing urine. Pupil, normal to dilated. Now what do you want to do? Okay. So after 6 hours of aggressive management, patient was still not improving. Okay. And we were inclined to think in terms of beta blocker overdose. And we gave targeted treatment for a beta blocker overdose, which is a high dose insulin with a dextrose infusion and a lipid emulsion, which has been recommended in textbook. Okay, so this was possibly a case of both calcium channel blocker and a beta blocker poisoning, because it was an unresponsive bradycardia, or a patient who was whose hypotension was unresponsive. So you initially treated the bradycardia responded to a certain extent, and then you were stuck in the hypotension issues. Now you have to identify which poison is causing hypotension predominantly. So possibly it's a combined poison of both. So you do activated charcoal, whole bowel irrigation, you give calcium. So now you are treating a calcium channel blocker poisoning as well. So you give calcium, you give high dose insulin, and you try to treat the combined poisoning. It's a common scenario. It is not that it is very uncommon. A patient who is on both the drugs may come up with an overdose of both the drugs. Okay, second patient, 34-year-old pregnant woman coming from Brazil, complaints of pain abdomen while waiting for bags at the airport. Initial examination showed GCS of 6, high BP, saturation of 93% on room air, and the patient had a generalized seizure, mydriasis, and intense sweat. It is easy. This is easy. Okay, this is easy. Okay. So she had crept, she had electrolyte imbalance, tropi was high, and this was the ECG. So she had tachycardia. This is the X-ray. So classical case of cocaine packets in the stomach. Okay, sympathomimetic poison, it's a cocaine poisoning. And what is the treatment of cocaine poisoning? You do it a symptomatic treatment according to the situation. So you treat the effects of sympathomimetic with the medicines accordingly. You treat the seizures, and you try decontamination with activated charcoal, and antidote is soda bicarb. Okay, so now what is the answer for this? Most useful bedside test to suggest snake bite envenomation. Which two? Whole blood clotting, 20 minutes whole blood clotting time. Okay, good. Now what is the answer to this? So 12-year-old boy, alleged history of snake bite, presented to the hospital, inability to open eyes and difficulty in breathing, very anxious, having tachycardia, tachypnea, bite mark cannot be visualized, no swelling at the limb, and he has ptosis. Okay, now what do you want to do? Yes, B or C or A? There is no bite mark. C. Okay, okay, good. So it is, you have to give ASV, you have to give neostigmine, and you have to observe the patient. So just to summarize, unknown poisoning is quite common, and specific antidotes are available for not more than 20% of poisons. And early diagnosis and stabilization is the mainstay, and usually we follow the two-pronged approach. Thank you. Any questions? Okay, thank you.
Thank you, sir.